Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It's Thursday. It's October 16th, 2025. And, I forgot it was Thursday, and Thursday's podcast day. And so I was scrambling for a topic and had been working on a presentation for a public group of folks who reached out to the college and asking, is anybody can talk to this group of people about immunotherapy? It's like, okay, yeah. So I've been compiling slides I have over the years about immunotherapy, and it occurred to me I had not talked about IL-2 a whole lot, or interleukin-2. And this is, I think fair to say one of the it is one of the forerunners of immunotherapy, and maybe not the forerunner. Maybe that goes to interferons. But interleukin-2 is a cytokine. It is probably the most important cytokine responsible for the activation and proliferation of T lymphocytes. These are the way interleukin, between leukocytes. This is how white blood cells talk to each other. And so this was a drug that was used, and we'll kind of talk about the history of that and some of the successes and some of the challenges and why it's no longer used a whole lot. So kind of the legend goes that there were patients with like renal cell carcinoma and metastatic melanoma, metastatic renal cell carcinoma. And these patients, to this day, we still don't use traditional cytotoxic chemotherapy for those two disease states. These are also two disease states, different parts of the body, but also, besides being unresponsive to cytotoxic chemotherapy, both have high rates of spontaneous hemorrhage with CNS metastasis, unlike, say, metastatic lung or metastatic breast cancer to the brain. So there's something shared about this, and both of these disease states would have spontaneous remissions, which was either miraculous or it was the immune system. And so scientists said maybe there's something to the immune system. They started playing around with cytokines in the lab. So interferon was one of the first ones, and interleukin-2. So IL-2, we're talking high-dose interleukin-2, was given initially in combination with like natural killer cells or some sort of lymphocytes or some sort of immune cells based on some laboratory data that this worked best. They figured out that IL-2 by itself worked just as well as IL-2 with the cell. So IL-2 was given to a whole lot of people, and in renal cell carcinoma, metastatic renal cell carcinoma, it was studied a whole lot. Actually got an FDA approval, and I think in 1992, and you would see objective response rates of around 20% plus or minus. And complete response rates of 5 to 10%. And the patients who had complete response, all the people who had responses, had durable responses. And those that had complete responses had very durable responses, to the point that many of them, now again, we're talking maybe 5% had a complete response, but many of them that had a complete response required no further therapy. And sometimes even have surgery, say to remove the kidney, and there was a pathologic complete response. So this was the first clue that maybe this, activated immune system could potentially even cure some people with very advanced disease. In renal cell carcinoma, we have similar data in metastatic melanoma, where we see kind of the same thing with response rates overall of 20%, complete response rates of maybe 5 to 10%, but with very, very durable responses. So when you look at some of the clinical data, you see the duration of follow-up is to 107 plus months, meaning at the time of publication, someone had been on or had received that drug and they were 107 months out plus, still without evidence of disease recurrence or progression. And this, of course, led to then, what is IL-2 doing? What's activating T cells? Is there a way that we can activate the T cells that are already there without using something as toxic as IL-2? So if you have a really bad case of the flu and you feel really crappy, it's really not the influenza virus that's doing that. Maybe that's what's causing the cough. But it's your body's immune system revving up and releasing cytokines like IL-2 that make you feel tired. And when patients come in and they're hypotensive, with really bad infection. It's cytokine release syndrome from all this immune system activation. That's what we would see with high-dose IL-2. We're talking 600,000, 720,000 units per kg every 8 hours for 5 days, for 15 doses. And if you ever do this at your center, you're not used to this. NIH published kind of the best practices in monitoring these patients with regard to their renal function, their blood pressure, their heart rate, because what they would see is, patients would require, 3/4 would have severe hypotension. You get hypotension, sometimes you get kidney failure, right? Nausea, shortness of breath from fluid accumulation in the lungs. You would have infections, and so you didn't want to, maybe have central lines in place, because even though IL-2 stimulates the immune system, it would cause some dysregulation, and there would be even some myelosuppression and some infection risk. And so you would always, follow these folks, and if the pressures respond to fluids, you could maybe do the next dose. If they needed vasopressors, you wouldn't do the next dose. If the renal function went down by so much and they had oliguric renal failure, you would not give the next dose. You would wait until things died down. And they were able to see that patients, even if they got 7 to 8 of the planned 15 doses, they still had about the same response rate. But you're talking, some of these people have to go to the ICU. If you go to the ICU, you might not make it out. So it's pretty toxic treatment. And that is why we don't typically use IL-2 anymore, right? So if you look at a current textbook or review article on current treatment of advanced renal cell carcinoma or metastatic melanoma, you're not seeing that, except maybe a sentence, as an allusion to the forefront of immunotherapy and how we ended up with immune checkpoint inhibitors, which are incredibly effective but have a much safer and tolerable toxicity profile compared to IL-2. So that's interleukin-2. It's really a fascinating drug / cytokine, a very important cytokine. Most of all the immunosuppressants that we use for autoimmune diseases, many of them work by decreasing the activity of interleukin-2. So it's important for the immune system, and was an important building block and foundation of our current immunotherapy landscape. So that is IL-2. That's what I have this week. Thank you so much for listening. You can follow me on X at PharmDeepNib and at OncoPharmPod at other social media platforms. And until I talk to you again, remember, doses matter.